in your spine that rotate, because there's a pair of them, are going to rotate to the right and left. So how do we begin describing how muscles affect rotation in the spine? Well, here's the deal. If you have an axis like a spine with a pair of handles, which is what the spine is, it's a straight axis with transverse process sticking out either side. And this, obviously not every rotator is grabbing onto the spine, but this same philosophy still applies. I can either, if I want to walk up and rotate this axis, I can grab one side and pull it. I can also grab the other side and push it, right? So whenever something is rotating, it has forces on both sides of the body. Is that making sense so far? Mm-hmm. Okay. So if we think about this as the sides of a vertebra, one side, if I'm doing left rotation, one side is moving posterior, but one side is moving anterior, right? So if we apply this to muscles, what we really need to ask ourselves is, if a muscle is a rotary muscle of the spine, is it going to rotate to the side that it's on, or is it going to rotate away from the side that it's on? Okay, this is how we describe the way muscles affect rotation. So you will see terms like contralateral and ipsilateral rotation. Ipsilateral means same side rotation. Contralateral means opposite side rotation. So where this applies now is with two of the abdominal muscles you're going to learn, called the obliques, your external and internal oblique. So I don't want to get specific in attachments quite yet. I just want to focus on this rotary piece, okay? So what I've done here is I've sort of taped a couple structures here. The first thing is this blue piece of tape down the center. You'll learn this is called the linea alba, okay? Yep. Yeah, so whatever you can look at it as a rectus abdominis, whatever it is, this, you just want to think of this as a centerpiece of the abdominal wall. And then you have a red piece of tape here and a green piece of tape here. What you're going to learn here in a bit is that this is a section of what will become your external oblique. Fiber direction is the same as if you were putting your hand into your pocket.
Quick question.
Yes.
The linea alba, is that white thing, the line that you see on the skin, or no? That's some people have it, not everyone.
Let's revisit. I'll come back to linea alba.
Okay.
So hold that question for me for just a bit, because I want to really focus on this concept for a second, and then we'll come back. So hold that for me, Jim. Okay. So you've got this center axis. So this is like the axis in the front. Okay. You have a red line coming across, right, like external oblique. Then you have a green line down here that almost between the two creates a singular pull from the ribs to the pelvis, right? A singular line. This is your internal oblique. Rather than putting your hands in the pocket, this direction is more like giving yourself a hug, okay? Fiber direction is this way rather than this way. They're moving in two different directions, okay? But how these muscles work is across the body. So, the external oblique on the right side is a synergism rotation with the internal oblique on the left side. Well, how does that work? Well, let's look at rotation. If I decide to rotate my spine to any direction, am I going to move my pelvis towards my ribs or my ribs towards my pelvis?
Your
Ribs towards your pelvis, right? No one's going to rotate like this. You know what I mean? We're going to rotate our ribs on our pelvis. So let's do that. Let's create a rotary moment to the left. And what I want you to see is, do you see how both of those tissues shorten? Okay. You all seeing that? When you shorten a piece of tape, by the way, it just gets floppy because it doesn't have proteins in it. It's easier to see that if I go this way, you see how it lengthens in that direction. Okay. So when I create left rotation, this is what I want you to understand. I am getting contributions from my right external oblique and my left internal oblique. You can see that clearly when I rotate it, right? So, even though my external oblique is on the right side of my body, which direction is it rotating?
To the left.
So is that a same side or opposite side rotator? Opposite side. Internal oblique is on the left side. It's contributing to left rotation. So that's a same side rotator. Does that make sense?
Yes.
Mm-hmm.
This is how we describe muscles as they contribute to rotation. And this is the only really difficult concept with today's lecture, is that when we look at rotation, what we want to ask ourselves is, does the muscle rotate to the side that it's on, or does it rotate to the opposite side that it's on? The answer to that question for these two muscles is, for external oblique, it rotates to the opposite side. My right external oblique will rotate me to the left. my left external oblique would rotate me to the right. Okay? Internal oblique is the same side rotator. So the one on the left will rotate to the left, the one on the right will rotate to the right. This is critical, guys, because when I have a client come,
the internal is same side?
internal same side, yes. Exactly right. So when I have a client coming in with clear rotoscoliosis and low back pain, I need to know what muscles to treat. I need to be able to say which, there's going to be muscles on both the right and the left side that are problematic. When I say problematic, I mean they're stuck in a locked position, they require work. But you would want to work the ones on the right that rotate opposite side and the ones left that rotate same side if they're stuck in the left rotation, okay? So that's the ultimate, that statement I just said is ultimately where you want your brain to go. Doesn't have to go there right now, right? Applying assessment here is, it takes a little bit of going through the motions in your head, right? But at the end of the day, okay, what I want you to understand right now is that some muscles are same side rotators, some muscles are opposite side rotators, or contralateral, opposite, ipsilateral, same, okay? Is that making some sense?
Contra or against?
Yeah, contra meaning against or opposed to, yeah.
Like contradiction.
Like contradiction,
Uh-huh.
or contraindication, right?
Exactly.
Yeah, meaning it's not indicated.
Mhm.
It is against indication or opposite of indicated. Yes?
What? Say that again?
Ipsilateral? I don't think ipsi we use too much.
No. I only think of
There might be a word.
there. Yeah, like there was this makeup I think or perfume. I don't know that it's called FC.
Is it?
I don't know why that came to mind.
Is that with an I or E?
I.
That-
Yep.
that's-
Yes. So you would think of this muscle coming up this way and this muscle as coming down this way. Because while this one is going to, well, actually you can think of it coming up too because it's going to pull the ribs. So I think they're both coming from the pelvis towards the ribs. Now, that's not going to serve you in the book because, and we'll talk about the arrangement in terms of how or why certain attachments were called origins and certain attachments were called insertions. No matter how you look at it, ribs are being pulled towards pelvis. There's no question that the spine and ribs are the main portion. However, external oblique, the ribs are considered the origin. It's not the most stable attachment. But what it does is it gives you a common insertion for 3 of your 4 abdominals, so it makes it easier to remember them because you can compartmentalize it a little bit. But that aside, the ribs are where the movement is happening. So these muscles are definitely coming up to the ribs and pulling down, right? Like if you do crunches, you're going to rotate, but you're also going to come down, right? You want to fire those muscles, you're collapsing that space. You can also pull your iliac crest up if you want to get more internal oblique involvement, right? You can really specify, like you can bring that knee in, but you really, more than bringing the knee in, you need to move the pelvis in. The knee doesn't really matter. I mean, if you're just moving your knee and you're just getting pectineus or TFL involved, you're just doing hip flexion, which is what a lot of people do when they do sit-ups, by the way. It's just a bunch of hip flexion. You know, they're never getting their abs stronger. So you got to really tuck that. But there's a pelvic portion that's important. So
Posterior tuck of the pelvis.
what's that?
Or that's what they say, posterior tuck of the
Yeah,
pelvis.
the more you can drive the pubic bone up, the more you're going to engage abs. That's for sure. That is for sure. Especially lower abs where most people are weak.
Yeah. Mm-hmm.
Like lots of really fit people are very weak. This is a tough spot. All right, so I wanted to start there. Does that make sense to everybody? Is anybody like totally lost on this concept? It's okay if you are.
A little bit.
A little bit? Okay.
I'm blank.
Okay. Okay. So if you think about, so what might help is this, guys. You know, if you're looking at all these muscles in the abdominal wall, what are they moving? They're pulling on ribs, but ultimately what's moving? It's the spine. It's all spinal motion. So you always want to think about the spine moving, okay? So, forward and back motions are pretty easy, okay? Side to side motions are pretty easy. They're just as easy, when I say they're as easy as anywhere else you learn muscles. Rotation is a bit tricky because what's happening on one side of the joint is happening opposite on the other side. That's also true of side bending, right? This is why the spine's weird. If I have a pair of muscles that side bend in the spine, If I shorten one, what's happening to the other one?
No.
It's getting longer, right? So they're never really working together. They're antagonists to themselves, right? So when the right side's shortening, the left side is lengthening. That's new, right? In the hip, it was like you had a muscle that was moving in a certain direction, and you had a whole different muscle that was an antagonist. Now you got the same pair of muscles that it's its own antagonist. Okay, so that's different. In rotation, it's especially hard because you have pulling forces from one side and pulling forces from the other side. Meaning that when you decide to rotate your spine to the left, you got muscles on both sides working. Okay? And that's problematic because if we describe rotation with the words right and left, we can't call, like hip rotation is medial and lateral. And muscles are either going to do one or the other, sometimes both. We can just classify them as medial and lateral rotators or as both a medial and lateral rotator. With the spine, we can't call them right and left rotators because every rotational muscle is going to rotate to the right and left. What we want to know is are the muscles on the right participating in right rotation, or are they participating in left rotation? Right? That's the question you have to ask yourself, if it's a rotary muscle on the right, which direction is it going to move my spine? Because depending on which side of the axis you're on, you might be more of a pulling force on the opposite side, or you might be a pulling force on the same side. This is your example, right? For left rotation, so your vertebrae are rotating to the left, you have muscles on the right side that are shortening and muscles on the left side that are shortening, okay? If it's on the right side of this line and it's rotating to the left, then it's rotating to the opposite side that it's on, right? It lives on the right side of the body, but it's not rotating to the right, it's rotating to the left, which means it's rotating to the opposite side that it's on. That's a contralateral rotator. But if it's living on the left side and rotating to the left side, it's the same side rotator. It's just a whole bunch of verbiage, you guys. Just a whole bunch of verbiage to describe how we can imagine muscles moving the spine.
Might be better for me to look at it in the app too.
Well, so after I lecture through the specifics, I'm gonna draw it on Asher, and you might be able to see it through the drawing a little bit better. That might help. Okay. I bet you do.
I bet you do. Oh my God, at the same time.
No,
Same time.
I actually didn't say that.
We
to
didn't
mean
say nothing,
anything else,
we just
but
said I bet you do both
it
of
will
them at the
help
same time.
because I'm like seeing that thing in it.
All right. So
Yeah, it smells so good.
let's talk specifics. There are 4 abdominal muscles: rectus abdominis, external oblique, internal oblique, transverse abdominis, and then 2 deeper muscles: psoas major, psoas minor. Sorry, psoas major and iliacus. We don't have psoas minor. There is a psoas minor, but not everybody has one, so it's not in your book. And there's no way to tell if you have one or not until you get cut open in an autopsy. So, or if you're getting like a deep surgery, and just surgery through the belly. Okay. Which it's not worth finding. It's just hopefully you're never in that situation. Now, a couple structures you need to know. The first is called the linea alba. So to go back to Gina's question, yes, it is a dense, kind of opaque or a white structure that runs right down the middle of the belly. And its job is to maintain a centrated pull for the abdominal wall towards the midline. So this often separates in pregnancy. They call that diastasis recti.
Yeah.
And that is a separation of the linea alba, which manifests as weak core after pregnancy, after birth, postpartum. A lot of women.
But you get the belly looking so weird because the muscles.
Yeah,
are
so
not.
weak belly, urinary incontinence, a lot of the typical symptoms that come with that. They're not like done deals. A lot of women who continue to pee on themselves, they don't have to, right?
What?
Yeah, you don't have to pee on yourself.
I carry underwear for the past 3.5 years.
That's right, you don't have to pee on yourself. You just need good postpartum training. You need good exercise.
They told me to do Kegels and they never work. But that's why we talked about it last week about this lady that had.
Yeah, I mean, Kegels, that's part of it, but
But if you don't know how to do it, it's kind of hard.
yeah, it can be a real science. There are people you can work with.
I just think it's very damaged. Like, we push a
Every time I
watermelon
sneeze,
out
I
for
gotta go like this.
private, so it's just.
You can call it a vagina, it's okay. We're in anatomy school. I mean, that's what it's called anyway.
Okay.
Yeah, so but yeah, you're pushing a large human head of your vagina. That's a
My
lot.
God.
That's a lot to ask. And you know, when you're giving birth, and I've sat in on 3 of them,
A little funny
it
situation.
doesn't feel like it's working. You're like, okay, I'm pushing and it's not coming out. It's not, you know,
Right.
it's clearly not a fitted relationship.
Did your wife have a C-section with any?
Vaginal births?
I did too when
I did C-section.
No. No drugs.
Thank you,
Yeah.
Jesus.
No drugs
Hallelujah.
all the time.
No.
Nope, no drugs at all. Drug free.
Wow.
Let me open,
I
give me
want to
drugs.
do that without medication because
Yeah.
my postpartum was horrendous because of the epidural and all the pain medication. My insulin stopped working, and it was
Yeah.
so if I had another kid, I will just go natural, 100%.
Yeah. Very good.
Anyways,
It's a hard
keep
call.
going.
Yeah. All right. So yeah, that's linea alba. There is also something you're gonna see called the rectus sheath. Actually, your book calls it the abdominal fascia. Either way is fine.
Rectus
So-
what? Shield?
So rectus sheath, but your book calls it like SHEATH, like a sheath. Like you put a sword in a sheath. Is that right? That's how you would use it. Sheath.
That's actually what the word vagina means.
Sheath? Fascinating. It makes sense. You think about
Why
sexual
would
intercourse,
Charlotte
it's like a
say
sword
things?
going in a sheath. That's-
Why when Charlotte says
That's how it
things,
works.
nobody says anything, but I say something and like,
The way you
Do
said
they
it.
really? I didn't notice that.
But wait,
say-
the book
All right.
calls
Say
it
it with
what?
enough authority.
What is the book called?
So, we digress a bit tonight, huh? So, abdominal fascia. So you'll see this block, this rectangle of white tissue. This is going to be your abdominal fascia, your rectus sheath. Your book uses abdominal fascia. This is sort of like what your
I don't
muscles.
see that in the book.
So if you look at insertions for internal, external, or transverse abdominis, you'll see linea alba, abdominal fascia.
Okay.
Yeah, so that's what it means by abdominal fascia, is this sheet right here of abdominal fascia, right
Is
here.
the linea alba fascia?
So it is very dense connective tissue. So it's not quite classified as fascia, but it is super
it's
collagenous, right
connective
down the center.
tissue.
Yes.
Hold on. So if the person is like my structure here with all this, really good. Where do you see that?
Yeah, so sometimes you gotta work through a little fluff.
Oh.
Yeah, so everybody.
So it's in there.
And so if you look at like,
But yeah, it's like the fluffiness is just fat.
if you look at
but-
an MRI of a large person,
I-
they've got muscles like everybody else. There's a
Right.
fit person underneath layers.
The rollies, yes,
The
we
rollies.
all have it.
Yes,
What's the difference between the aponeurosis and the sheath?
nothing.
I couldn't hear.
Just terms. What's the difference between aponeurosis and a sheath? Here's why it's called a sheath. It's called the sheath because it surrounds the rectus abdominis. So it creates a sheath around the rectus abdominis. So if you were to cut the rectus abdominis and pull it out to look at it, it would be layers on the posterior and the anterior side. So it's surrounded. I think that's why it's called a sheath, because it's sheathing the rectus abdominis. That aside, it operates like any other aponeurosis.
So how's
make
the
sense?
name in the book? I'm
Okay.
sorry, I don't have the book.
Abdominal fascia.
Okay.
Yes.
So the abdominals are encased in the sheath.
So rectus abdominis is, and it's formed by your other abdominals. So if you ever pull up a picture of your obliques, you'll see something like this where it's muscle, and then it's just this long flat tendon that's feeding into the center line. And this is a bigger conversation about, like, the tendons for your abdominals are much different than any other muscle. They're not these singular cylindrical tendons, they're flat and broad because you don't have a bony structure, it's just squishy bits under your belly, which is problematic for movement, y'all. When you move, right, when you move around, the risk of tearing these muscles is much higher than muscles that have a hard backdrop to them. So that's why, here's another thing you need to know. You see these lines moving through your rectus abdominis that make the six-pack appearance? Those are called tendinous inscriptions. I would write that down.
Tendon is what?
Tendinous inscriptions. Okay.
Inscriptions.
Correct. Tendinous inscriptions. And those are there to mitigate ballistic forces that could potentially tear tissue. Meaning,
So
when
if
you
you're
go to
fluffy, it's
link,
good.
Can you write
So-
that down?
yeah. What's that?
Can you write that on the board?
Asher, can you please get out of your phone and write things down?
You know what? Why are you bossing me around? I can't
Called
with you.
out.
That's-
You know.
That's Laura. His handwriting is
You're
probably better
assuming
than
I
mine.
can spell.
Ay, Dios mío.
Oh, this will be fun, yes.
What?
I'm
Like,
not-
how
yeah.
much you pay him per hour? Lower it.
I can't spell, so I won't even know the difference.
You don't, what's that?
I have a question. What's the difference between the rectus abdominis and the rectus sheath?
The
then?
rectus abdominis is the muscle, and the sheath is the sheet of fascia.
That gives it structure.
Oh, I thought you said.
Now you're talking.
Okay.
Yeah, so if we go back, so you guys are confusing yourselves
So-
on things that aren't even meant to be confusing today.
Okay.
So it's gonna be a long night.
So I'm just confused, like, so say when you do a tummy tuck procedure in surgery, and you lift up all of that fat, right, and you're down on the abdominal wall,
Uh-huh.
okay, and you're looking at the fascia and then the muscles and the separation.
Are those-
Where
Oh,
is the
yeah.
rectus abdominis? The
Are
whole
those
thing
only
is what you're referring to as that, or, cause you can see the
So here's
different
what I will
muscles.
tell you. If you were to cut the rectus abdominis and look at it from the inside, what you would see is muscle fiber, okay? Muscle fiber, right, like any other muscle, okay? But what's happening is this sheath is coming around from your other abdominals and surrounding it, right? Layer one. And then, so that would be like transverse abdominis. And then internal oblique comes in and creates another layer of sheath around it. That's layer two. This is your abdominal fascia, rectus sheath, whatever. And if we imagine a third color, we'll use red again, that's also surrounding it. This sheath is formed by your other abdominals. So rectus abdominis, literally, it runs vertical up your torso, but if you were to cut it and look at the inside, it would be surrounded from the front and the back, which is why it's a sheath. If your rectus abdominis was a sword, it would be sheathed inside of this casing. That make sense? It does not make sense.
Am I looking at this, how am I looking at this, like their feet, like they're laying down?
So no, it's like if you took rectus abdominis, cut it, and turned it that way. It's a transverse cut.
Okay, so basically if you pull all the skin back and the fat, right, and you're looking at it, you're
Uh-huh.
looking at all of these muscles, they're just kind of all within each other.
Here's the problem with that, Nicole, is that's not a muscle anymore. What's the difference between a tendon and a muscle?
Tendon attack is not-
Fiber, or,
Forget about definitions. What is physically different about it? It's the same bag. If I take a muscle with its tendon, okay, which is what you eat when you eat meat, you have this clear sausage of meat that then becomes tendon, okay? So, what's the difference?
Just together.
What's that?
Smaller.
So it gets smaller, but why does it get smaller? What is it losing?
muscle.
It's just losing the proteins that make muscle, the actin and myosin, the proteins inside the bag that create contraction. All you're doing is getting rid of them. And then you get pure tendon. So this is the same concept here. These abdominal muscles are wrapping. So if we were to look at this as a transverse cut, the spine would be here in the back, okay? And then you'd have like all your organs and stuff in the belly. And so these muscles are wrapping around like this. Their muscle here, then they just become tendon. So this is the only protein, this is the only muscular component of the midline is the rectus abdominis. At this point, all these other muscles have just become thin layers of fascia, pure collagen. There's no muscle in there.
Okay.
You get what I'm saying? It's no longer muscle.
You're shaking
That's
your
why-
head like, yes,
That's
but
why
no.
this is white. When you see white like that, that's not muscle, y'all. That's just a broad, flat tendon.
And it's like the
Okay,
tough,
so we're not really
the
talking
tough
about
part
the
of a
muscle.
piece of meat, like when you cut it, it's good. Sometimes there's like a really thick like layer surrounding it.
Yeah, like an
the
orange,
tender-
and then you have the
Yeah.
white peel, the white stuff.
Exactly right.
So the orange part would be the muscle,
Yes.
and the white
So
part.
when you cut an orange open and you see that triangle of fleshy pulp and that white around it, okay, this is the white around it. It is formed by your three other abdominal muscles, internal, oblique, external. So we haven't even got to the muscles yet, right? I'm
Okay.
just letting you know of structures that are here, and you guys are wanting to dive deep, which is great. But this is when we say rectus sheath, we're talking about the flat tendinous components of your other muscles. They just happen to wrap that center muscle completely. They create almost their own bag around rectus abdominis. It's very unique, right? But if we took this and stood it upright, that's what we see it on a human. But if we were to sever them in half and look in fact, what you guys might want to do is just type in transverse cut abdominal wall, and you'll see this. You'll see the whole abdominal wall, but you'll get to see what I'm showing you, that rectus abdominis with the surrounding sheath.
So after you like make an incision and then you are pulling up the fat and you're cutting through fascia, you know, it's a very superficial layer. Is that one of the things we're talking about? Is that the rectus?
It is not. So when you cut through a body, you're in the areolar layer. That's superficial fascia. That's where the fat is.
Superficial fascia.
When you
Okay.
removed all that, you'd see the next layer of fascia,
Okay.
which every muscle has. This one is 3 layers deep. Sometimes you have a
Okay.
single layer of fascia called the fascia lata.
Okay.
That's still deep to the fat.
Makes sense now. Yeah.
Yep.
Okay.
I actually have a fascial atlas in my room. I'll pull out so you can look at it.
Okay. I think that was what was confusing me because I
Yeah.
know when you cut through fascia, I was trying to figure out where I was at on that.
Yeah, so you're deep to the fat. You're deep. You're there. Now, all the fat's gone on that picture.
Right.
There's no fat there.
Okay.
Except for what's in the muscle. Right?
Okay.
So if they're a really fit person, they're going to have a lot of fat in their muscle. Okay. But when you go through that fat, you're going to see this rectus sheath. You'd have to cut through that to see the muscle.
Right.
Okay.
So the rectus sheath is what we're looking at, and the superficial fascia is what we cut through.
Yeah, so you'd have to
Okay,
cut through
okay.
the superficial fascia to
Okay,
get there.
okay.
Yes. Okay, so that's rectus sheath.
Transverse, abdominal.
Yeah, we haven't even gotten into the muscles yet, but it's
Okay,
formed
so,
by those
no,
muscles.
what you said to look in the,
Transverse cut.
oh,
Just put transverse cut if you want to see. Okay. Yeah, let's kind of let that one rest for right now, guys.
Okay.
It's just a place that muscles are going to attach into because they're formed by it. Okay. That's the abdominal fascia. Okay. The last thing is called your inguinal ligament. That's the last one you need, and that's this ligament right here. Okay. That ligament right there. It runs from your ASIS to your pubic tubercle. It's in your book as well if you want to see it there on the bottom page. But that is your inguinal ligament. So that's another point of attachment you're going to hear today. You're going to hear inguinal ligament. You're going to hear linea alba. You're going to see abdominal fascia. You also need to know tendinous inscriptions. Okay. Okay. Those are important. All right. So let's talk through these and then we'll get Asher on the table. Okay. So let's start with your first abdominal muscle, which is rectus abdominis. Okay. Rectus abdominis is a very vertical muscle, so it's going to originate on the 5th, 6th, and 7th ribs. You can see those blue spots right there. That's rectus abdominis. It's going to travel straight down to insert on the pubic bone, anterior pubic bone. Straight shot down. Okay. If you were to shorten the angle between the 5th, 6th, and 7th ribs and the pubic bone, you would get what a lot of people call a classic sit-up, but what we would call spinal what?
Flexion.
Flexion. It's a spinal flexor. Now, I'm going to tell you this now, guys, because it confuses people. You can say spinal flexion. Your book will also say flexion of the vertebral column. It might say flexion of the torso. It's all the same thing. All of it's moving the spine, so don't get lost in the language. Okay? If you flex the torso, just like it can be hip flexion, you can call it thigh flexion. You can call it flexion of the femur. It's all the same thing. Sometimes you're describing what's moving, sometimes you're describing where movement's happening. It's all the same. Don't get lost in it, okay? It's all a crunch. It's all just a crunch, okay? Now, you're also going to see compression of the abdominal contents. That is something that all 4 abdominal muscles do, by the way. All 4 of them are going to compress the abdominal contents. So I don't need to mention that again. It's something they all do. And that, if you want to feel what that feels like, then purse your lips and blow like you're blowing up a balloon. And you'll feel your abs turn on, right? That's your transverse abdominis primarily, but all your muscles are contributing to a compressive moment. And that's how you would want to move weight around, is with an exhale like that. Because that increase in intra-abdominal pressure is going to stabilize your lumbar spine, which is good. You never want to lift weight while you're holding your breath. It's a recipe for injury, okay? Because you're increasing load, but you're not increasing pressure forces. So you're increasing the load without increasing the stability, which isn't good. Yeah. Yeah, there are stories of people lifting weights without breathing, and they literally blow a hernia out, like or blow a disc out. Like they get a disc herniation from it, which is crazy to think about. But you can blow a disc out from that. Obviously, a really bad injury. Okay. All right, so that's rectus abdominis. It is a flex. That's easy. That's straightforward, guys. Ribs 5, 6, and 7 to the anterior pubic bone. It's a spinal flexor. Okay. Now from there, we're going to move to external oblique. External oblique originates on the lower 8 ribs. Okay. It's going to travel across to the abdominal fascia, linea alba, and iliac crest. So it's essentially a fan that looks like that.
Crosses what?
Crosses the, well, it's just here. Just crosses the abdominal wall. Yeah, I don't think that the word crosses was relevant. It's just that
Okay.
it's going to go to the linea alba, abdominal fascia, and iliac crest. So like I said, it's like putting your hand in a pocket. That's the fiber direction of these muscles, okay? Now, I'm just verbally lecturing. When I draw them on Asher, it's going to be more visually, it's going to click a little better. So just, if you're just taking it in right now for the first time, that's fine. So when I do it on Asher, it'll be the second time you've heard it, okay? So if we look at these fiber directions, we're going to have fibers very lateral, like my pinky finger, that are going to laterally flex. We're going to have fibers that flex the trunk, flex the spine, and then, like we talked about a little bit ago, it is going to perform contralateral rotation. Okay. You need help with the page number, Jean?
Yes.
Let's help her out.
It's 169.
169.
167 actually.
6'9" or 7'9"?
7.
Mm-hmm. Okay, so contralateral rotation, and of course, like we said, compression of the abdominal contents. Right? For internal oblique is originating on the inguinal ligament and iliac crest, and then it's reaching up the abdominal fascia, linea alba, and if my fingers were long enough, the lower 4 ribs. Okay? So it's a fan that doesn't run this way, it's a fan that runs this way. Up from the iliac crest into the midline. Okay? That's going to be internal oblique. Internal oblique moves the body the exact same way that external oblique does, with the exception that it rotates to the same side versus the opposite side. Otherwise, it's the same. Now, you're going to notice that your book breaks down unilateral versus bilateral action. Just so you guys know what that is. We actually have already talked about that. What that means is that is one side working or both sides working?
Uni together.
Uni is just one,
One side.
singular, whereas bi is two. Like uno, that's right. So, easy way to think about this, guys. If you're moving in the frontal plane, are both sides working together, or is one side shortening, one side lengthening?
One short.
So only one side's working, right? So that is any lateral flexion will always be unilateral, because only one side can do it. Okay. What about rotation? One side shortening.
Bilateral.
Is it?
No, but it
One's
says
pushing, one's
bilateral.
pulling.
But we were talking about two different muscles though. If we look at the same muscle, external oblique, so let's move this right here temporarily. Okay? Because I get your rationale there, Nicole, but if we're looking at two different muscles, okay, but let's create the same muscle twice. So external oblique there, and then let's create that same muscle on this side, another external oblique. I don't think it'll be long enough, but it will still give us here. Okay. That'll do the trick. So, if I create left rotation, the red piece of tape will get shorter, but what's going to happen to the green piece of tape?
It's gonna move.
It's going to get longer. So if you think about, if you can imagine this is stationary, it's wanting to move on the pubic bone. The attachment on the ribs on the left side are moving farther away from the midline, correct?
Mm-hmm.
But on the right side, they're getting closer. So while my right side during left rotation is shortening, my left side is lengthening. Okay? So in rotation, your external obliques are going to shorten on one side and lengthen on the other. Okay? The only time you get bilateral action is flexion and extension. Because flexion is going to shorten both sides together. and lengthen both sides together. So if you want to keep it really simple, the only possibilities for bilateral action are flexion and extension. And considering we're dealing with all the flexors of the spine, well, that makes it pretty easy. The only bilateral action you're going to see is flexion. It's the easy way to think about it, okay? Everything else is going to be unilateral. All right? That leaves us with transverse abdominis, the last abdominal muscle. And its origin is similar to the last muscle we just learned, in that it's also originating on the inguinal ligament, also originating on the iliac crest, but it's going to continue into the thoracolumbar fascia, which is like the rectus sheath for our back. And it's not sheathing anything, so we just call it an aponeurosis, okay? But it is in the lower back, and it is going to rotate, shouldn't say rotate, the fibers are going to run horizontal around back to the midline. So it is feeding from the back into the abdominal fascia, linea alba, and pubic bone. So it looks like a corset. Think of it like the corset of the body. It's really what it is. It's the corset of your abdominal wall. It is a pure stabilizer and compressional muscle of the abdominal process.
You're talking and it's like, I didn't touch anything, it's just taking, you see?
Oh, just pulling up like websites and whatnot.
Yeah.
That's wild. Phones are weird. Always listening. man.
Kind of
Always
scary.
listening.
Oh, there it is.
Okay.
Okay,
I
so
see.
that's like the corset. So you're not gonna see any movements there except compressing the abdominal contents. That's all it's credited into. Okay.
Is the transverse abdominis above the internal oblique?
Great question. So they're listed in your book from superficial to deep. Rectus abdominis, next would be external oblique, then internal oblique, then transverse. Transverse is your deepest abdominal muscle. Good question. Okay. So when we talk about abdominal muscles, those are the ones. Those are the four. Okay. We're going to revisit those when we draw on Asher. There are two more muscles I want to cover today: psoas major and iliacus. I think you just got to flip the page a couple times. These are a little bit easier. Okay. So both of these muscles are going to share a couple things. First, they're both sharing an insertion on the lesser trochanter of the femur. They're both doing that. Okay, they're both inserting on the lesser trochanter, right? And they're both performing hip flexion. Okay, that's similar to both. I will say you will need to add that iliacus is your prime hip flexor. So number one, it's in your clinical notes, but if you want to write it down too, that's great. Primary hip flexor is iliacus.
Iliacus?
When deriving
Is what?
like a study method or whatever, when it says the action for the psoas major, you mentioned that it is hip flexion. The other stuff, do we need to know the other stuff as well? Like,
We do. I'm going to come back to that. I'm starting with what's common about both of them
Okay, cool.
because I think it lessens the amount that you have to learn.
Right.
So I like to, just like when I mentioned all four abdominal muscles compress abdominal contents, I think that helps feel like it's less information. Yes,
Which one was the primary hip flexor?
iliacus. Iliacus. Yeah, the primary hip flexor. Yep.
Ooh.
Okay. So origin is different for the both. Psoas major is originating on the lumbar spine as well as T12 to L5. You'll see it includes the vertebral bodies, intervertebral discs, right, transverse processes. So it's really invested. In fact, there's a model right here that we're looking at. Okay. So there is your psoas right here. Okay. So it's invested in the discs, the transverse processes, the bodies, and then it's traveling across the pelvis into the lesser trochanter. Okay. So when you shorten it, it's going to give you inflection. Okay. Iliacus is its counterpart, and it's originating in the iliac fossa. Okay. So it is originating on the pelvis, which is this is why it's your prime hip flexor. It's originating on a very stable, like if I'm going to pull from somewhere and I want it to be strong, I'm going to pull from the iliac crest or the iliac fossa. The lumbar spine is super unstable. I mean, it's a terrible position to get strong hip flexion from, okay? So iliacus is way better positioned for flexion because it's anchoring to the pelvis, which is far more stable than the spine, right? And that's why it's the prime hip flexor. It's just a better position to do the movement, okay? So the origin is different for those two. And like Jarrah was saying, for psoas, probably more important than its role as a hip flexor, because you got lots of muscles that do that, it is really an important muscle for stabilizing the lumbar spine, right? And so if we then ask the question, how many people do you think have an unstable lumbar spine? Well, it's going to be almost everybody, yeah. I mean, there are very few people with stable lumbar spines, very, very few. It is a full-time job almost, because we just don't move our bodies the way they're designed anymore. You have to make time for it, and our culture doesn't accommodate that. So, it's a problem. It's a very big problem. So, we'll get into more of that tomorrow. But its job, and the way it's described in the book, I like it, because when you say a muscle is a stabilizer, that doesn't really tell you anything. There's lots of ways. Every muscle in your body, by the way, is technically a stabilizer. If it's ever an antagonist to emotion, it's stabilizing. But some muscles have bigger jobs, bigger roles in stability. This is one. It is really managing a position of extension. So the way you're reading it in your book is it is combating excessive lumbar flexion. Meaning when you sit down and you go into that upper cross position, psoas will turn on neurologically to try to pull you back. It really wants you to be in neutral. It's going to lose that battle, right? Because at the end of the day, gravity is going to win, body position is going to win, and your body will just conform to sitting as neutral, right? This is where it affects people the most. And that becomes a position where psoas is enormously tight. And you're looking at probably a root cause of low back pain.
You know, it's interesting, after starting school, after we've heard it so much personally, my mind makes, even when I'm working, minutes to get up, just to make sure that I'm in the right position. So I don't know if everyone is going through that, but I've noticed that it's changed, it's shifted the way I think
Yeah.
of my body.
I'd hope so, right? I mean,
Body awareness.
getting into this field, it just depends. I feel like for me going through school, I was 19 years old when I came through school, so like, I didn't have body issues. I think I thought about stuff, but I was more just interested in the knowledge and the application. Now that I'm 40, it's like, oh yeah, I've had that pain. Like, you know, it gets a lot more real, so you know, you're able to relate with it better, but you know, so it depends. Some youngsters might just be like, they don't, you know, they don't really have pain. You know what I mean? But that won't last forever.
I
Yeah.
do get more aware with like looking at my baby, because she's just always sitting very straight. Like this morning, she's like just pointing like this, and I was like, oh. So
Kids
yeah,
can be good
I've been
reminders,
more
yeah.
mindful too.
She wanted to.
Is the reason why that muscle isn't, like the sitting thing, is it because that muscle's always shortened?
Psoas? Like, why is it problematic during sitting?
Yeah, that
So-
low back pain,
Yeah, so if you're sitting, you are closing the angle of that muscle, so you are shortening. Psoas operates best as a hip flexor beyond 90 degrees, so unless you're sitting with your chair higher than your knees, it's going to be short. It's going to be in a compressed position, so. But more importantly, as a stabilizer, if you're not living, and this is a big part of our conversation tomorrow, is like, you can come see me every day of every week and I can't give you a healthy spine. Like, if you want a healthy spine, you have to put in the work. You have to move your spine. There's no shortcut. I can really help guide you to the right place, and I can give you the space to do the work, but you have to do the work. So, with that being said, that's another big piece of it, is sitting just compresses and starts to turn off the neuroproprioceptive feedback loop in your spine. It really shuts it down, so there's not a lot of, there's just not a lot of capacity there. Like, there's a lot of people that if you try to get them to move their lumbar spine, they can't. Like, if I sit them down and have them forward fold, their whole lumbar spine moves as a chunk.
right?
And they cannot independently move each vertebra. Are they designed to move independently? Hell yeah.
Yeah.
Like, absolutely. But they don't. Like, they can literally forward fold and I can eat dinner on their back. You know, like you can lay a plate on there because there's just no movement there. So you've got to find a way to get it. There's no, body work helps, but they have to move their spine. They've got to participate.
Why aren't they moving?
Why aren't they moving? Well, that's a complex question. What do you think the number one reason is?
See? I'm sorry.
Well, besides that, they don't know how. Most people don't know how they're supposed to move their spine. Most people are lost in what movement looks like. Even athletes, people who, like, unless they're in a specialized movement, they don't know what functional is. They don't know what good versus bad movement is. They don't know what's healthy or not. They're just, well, my coach does it, so I do it. Even if they're doing it wrong, right? What is wrong movement? And it's variable person to person, but there are principal rules that define functional movement, right? right? You have to work within the appreciable ranges allowed in that joint. You have to honor the planes available to the body, and you have to stay in them with the appropriate amount of load. And you have to do that regularly. You have to follow those rules constantly. That's functional movement. And so there's some variability there in what's allowed, right? Like even in terms of purely on the base of sex, like a female range for certain vertebrae is different than a male's. Like that's just part of the sex differentiation, but it's pretty negligible compared to what's generally allowed, right? But you have to live in those ranges appropriately under the right load on a regular basis within all of its planes of accessibility. That's functional. So like, can you crawl? Crawling is a pretty functional movement. You did it a lot as a baby. Most people
Hopefully.
cannot crawl. What's that?
I said hopefully.
Hopefully you can crawl?
Yeah.
The answer is most people cannot crawl.
Yeah,
Can you
most-
roll?
Of course, Charlotte.
Because don't babies
So Charlotte's crawl is not very good.
Really?
Oh, no!
But no, what I'm saying is a lot of babies
Well, we're not here to
don't
dissect the crawl
a
right
lot,
now, but-
right? It affects their spine.
What's that?
I said a lot of babies don't crawl like they should, and it affects their spine, correct?
Yes, my daughter,
As a baby.
my daughter did this. Like literally, that's how she did
They go from,
until she walked.
Oh yeah, that.
yeah, a lot
mine
of babies
too.
don't crawl enough, right?
Yeah.
Or they'll
So, I don't want to say that. So all the phases, all the milestones of movement for a child, for an infant, are very important. From the first to the 14th month, there is a strong correlation as well with certain milestones physically that correlate with mental milestones. That is undeniable in the research. So we don't really get to make that call. We had a conversation this morning about movement patterns in young people, and my answer is generally, almost all the time, it's behavioral or neurological. It's not muscular.
What? So my daughter crawling that way was
I'm not
weird?
making that call. I'm just saying, and we don't have to read too much into it, right?
Right.
I mean, it could just be that a young child had palmar and knee sensory issues, so they just stayed off. Doesn't mean that they're going to have autism. I'm just saying, like,
Right.
there's a correlation. Young children who are diagnosed with behavioral or neurological issues tend to have irregular movement patterns.
My
That's
kiddo
very
has
common.
sensorial issues.
Okay, so there you go. Now, if
But
that,
it's fixable, they just do OT and just kind of teach her. those
that
kind
might
of-
work for her. She may just grow out of it naturally. She may never grow out of it. It may go away and come back. We don't know. Right?
I just didn't know
But-
the correlation with that. I just hear my husband say it all the time. How our youngest, because he didn't crawl enough, he was walking at 8 months.
Yeah.
So he's always saying he should have crawled longer or more.
Yeah, so what happens, and
I
one of the
held him
biggest
all the
problems
time.
with Charlotte's crawl is she lacks spinal weight. She lacks because crawling is a extension of your fish body. You should be, if you watch a baby crawl, there's a whole lot of side bending that goes on. Not a top to bottom wave, a side to side wave. Charlotte's actually very stiff with that. She can't connect her lower motor cylinder with her mid and upper cylinder. They're disconnected.
But
So
she's
it's
super flexible. I think that could be.
So again, I don't want to dive
mobile.
too much into assessing a crawl right now. That's not our job.
Sorry.
Because it can get very detailed, right?
Yeah.
Maybe in a small group break we can do that. But there's a lot of things about Charlotte's crawl that can be fixed. And her crawl fits her personality, by the way. It does, but it's not functionally correct. That doesn't mean that her personality is
Well, then
dysfunctional.
show us how you're supposed to crawl.
That was cute.
So here's the thing, guys.
Back to the box.
Getting back to it. Okay, getting back to it. This whole conversation was based off of simply the role of stability of psoas and the lumbar spine, right? If we don't do things in our spine, crawling is one of many things you can do. Crawling is very hard, by the way. Most adults cannot crawl. Just letting you know, they cannot do it well. Okay, that's not abnormal. It's very normal. Just don't do it. Just don't do it. But it is a healthy movement, right? It's a very healthy movement. Okay, so we'll talk more tomorrow. But Charlotte could totally fix it. She just needs guidance. She just needs guidance on what a good crawl looks like, right?
Okay.
Have
And
you ever
therapy
laid
by
in a
the sounds of
bed
it.
and you've had back pain and you're like, how in the world do I get up? If you've ever had that, then you don't know how to get up off the ground. Like, people don't know how to roll anymore. Babies know how to roll really well because they don't have anything but a core. Rolling is pure core. but most people cannot roll. And where it becomes real is when you have back issues and you're lying down and you have to get up. If you lift your head first, that is not proper. You can't do that. But watch how many times you do it. You
I
lead.
sleep with a pillow.
You
to
lead
my
with your
legs.
head.
I can't.
That's not correct.
Yeah, okay.
You know, there is all you should be able to. You should be able to roll from your back to your belly with 0 extrinsic muscles. It should be pure core. But that's one way to practice spinal waving, spinal motion, right? It's all spinal core, but it's hard. It's really tough to do correctly.
I was very curious by, like, you know, everybody will tell me, like, well, your kid doesn't crawl yet. And I always thought that because she was such a fat thing, it was just kind of hard for her to move her body.
Could be.
And she actually walked kind of late, like at 14, almost 15 months. And people was like, you gotta check your kid. And then that kid was running.
But you know what?
But I thought it was because she was so fat.
I'm gonna tell you what, weight has nothing to do with functional movement. There are a lot of overweight people that move beautifully,
Oh my
gracefully,
God,
and
yes.
functional. Weight has nothing to do with it.
Mm-hmm.
People think it
Oh,
does.
yeah.
No, yeah, dude, there are. There's this woman on YouTube that does like a virtual yoga class. She's a
Oh my
larger
gosh,
woman.
she's so
Her
pretty.
movement, she's very graceful. She's a large woman.
Yes,
She's
she
big.
is.
You know what I'm talking about?
Yes, I do.
All right, I'm gonna have.
Oh,
Can we clear up this table? Thanks. Yeah, we're gonna do a.
Oh, the thingy, thingy, thingy.